yesterday, so it's important to be there.
Yeah. So I see Miss Val is on,
Yes.
and let me see who else of our voting members are on.
That's the only one I've caught so far, other than you, Dr. Schuster. So if you see someone that I missed, please let me know.
Okay. I know that Mike Berry has no internet. He's down in Florida. I said, if you're going to be without internet, nice to be in Florida.
Yeah.
But he is not able to be on today. Mary Haas is on, or just joining.
Yes, I just admitted her, and I'm sorry,
Lidovic, yeah, okay,
So that means you do have quorum.
good. And I think that Steve Shannon was going to try to join. He's over at the legislature. He was going to try to join from the library over there. And I see that Commissioner Lee is on. Wonderful.
Would like to take this opportunity to remind the members that in order to comply with open meeting laws, whenever you are voting, please make sure you have your camera on. Thank you very much. And with that, Dr. Schuster, I'll turn it over to you.
All right, thank you very much. And do we have a baby? Has Erin had her baby?
Yes, ma'am. She has had a little boy, Miles Joseph.
Wonderful. Well, please extend our congratulations to her and a welcome. Is it Miles? Did you say Miles Joseph?
Yes, Miles Joseph.
All right, that's Erin's new baby boy. Great. So we like to grow those Medicaid ranks. So welcome to you all. This is the Behavioral Health TAC meeting of March 9th, and I'll call the meeting to order. I'm Sheila Schuster with the Kentucky Mental Health Coalition. We have with us voting members of the TAC, Valerie Mudd, representing consumers through NAMI Lexington and Participation Station. Mary Haas, representing the Brain Injury Association of America, Kentucky chapter, and TJ Lidovic, representing NAMI Kentucky. I know that Mike Berry cannot be on. As I said, he texted me today and said that he has no power and his phone's not working very well. So we do have a quorum, so we will go on and
what did you say before about I need to find your other one.
I'm sorry. Is someone talking to me, or have you forgotten to mute? If you're not speaking, please mute your line. Thank you. I distributed the draft meeting minutes of our January 5th meeting and would entertain a motion from one of our voting members to approve those minutes.
Also move.
That's Mary Haas. Thank you, Mary. And a second, please.
Second.
Second from TJ. Thank you very much. All those in favor of approving the minutes as distributed, say aye.
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 Right. And any abstentions? Negatives. Okay. We're delighted to have Commissioner Lee with us. It's been a little while since he's been able to join us. So I'm going to move right into the Medicaid data study because the folks from data analytics are here to present that. And I want to do it while Commissioner Lee is on. you all who have been coming to these meetings regularly remember that this study was initially done directly with Medicaid in a little work group that we had through the BH TAC. I see that Dr. Brenzel is on. He's been a member of that work group. Steve Shannon and me. Mark Kelly was on until he left Pathways. Kathy Dobbins from Wellspring and Natalie Harris from the Coalition for the Homeless. And Commissioner Lee had kind of challenged, asked the question, let's look at the data on the use of targeted case management. So the Medicaid staff could not have been more helpful in terms of working with us. We developed a design that kind of looked at an 18-month period of 6 months where they might not have gotten targeted case management, 6 months where they got targeted case management that was part of the study, and then the 6 months after. After we pulled together that data, Commissioner Lee suggested that we share that in our design study and so forth, study design, I should say, with the folks at Data Analytics. And they have done certainly a higher powered analysis than we were able to do. And so we're very grateful to that. Are they on? Can we share that screen? Oh, there's Steve Shannon. Kelly, if you might reflect in, that Steve Shannon has joined us. Commissioner, do you know if the folks from Data Analytics are on to make the presentation?
Yes,
Dr.
I'm
Schuster.
here.
I'm
They
sorry.
are. Kelly, can you make Dr. Connor and Ben? Yes, thank you. Co-host, thank you.
All right, can you all see my screen here?
Yes,
Okay, great. So I am Dr. Kaylin Connor, and I will be walking you through the study on what the Office of Data Analytics did on targeted case management and health outcomes for individuals with serious mental illness. And we performed a cohort study, and we'll talk a little bit about what that means during this presentation. To go over what we'll cover today for you all, we want to review the findings from that previous work done by the Behavioral Health TAC, because it was such great work and gave us a lot of guiding measures for what to do in our study, and overview our questions for research in the context of this analysis. We want to tell you a little bit about the methods and the methodology we used for our study to give you a little bit of an insight into what exactly we did. We're also going to examine those population demographics for our population with serious mental illness, especially those that receive targeted case management. One of the main goals we wanted for this analysis was to really get to know that population and understand who those people were that were using this service. And so we thought this was a really important piece to highlight here. And then we'll examine those findings from the analytical study we conducted. So again, as Dr. Schuster mentioned, the TAC work group had an 18-month study they performed where they looked at the individuals with a serious mental illness that received TCM within that 6-month window. So they examined their 6 months prior to the TCM use, permitted a 6-month washout period, and then examined the 6 months after. And in total, their population consisted of a little over 6,000 individuals, I believe around 6,200 individuals. And their population included only the individuals with serious mental illness. So we borrowed that population and that idea for our analysis, even though there are the youth with serious emotional disturbances included in that regulation, and people with substance use disorders included in that regulation. We chose to focus solely on that SMI population for the purpose of this study. So the TAC study largely found increased costs to MCOs over the 6-month period following the receipt of TCM by approximately $6.1 million. Their net additional cost per person that they found equated to about $1,045 per person over that 6-month period, which equated to about $175 per person to the MCO. And they noted that that's about 52% of the monthly rate for targeted case management services for this population. So what we wanted to do to expand this was to look at the health outcomes associated with targeted case management for individuals with SMI to investigate some of those other measures established by the TAC as like areas of interest. And then we also wanted to further examine those costs over time to examine whether those differences in costs did persist following that 6-month period in our study window. So we'll go over some of our methodology now. We used a cohort design, which means we separated our population based on their receipt of those targeted case management services. So we compared individuals with targeted case management to individuals that did not receive targeted case management. And we made that population consist solely of adults aged 21 to 64 that had a diagnosis of a serious mental illness. And to be considered as having an SMI in this population, we also required 2 outpatient visits for the same SMI diagnosis or 1 inpatient hospitalization for an SMI diagnosis. So we also expanded the time period that we looked at. We looked at the time period between 2017 and 2021 and examined anyone diagnosed with an SMI that between this time period. So we had a 5-year period compared to the 6-month period that we were examining in our study. And again, as I mentioned, we divided our population with SMI based on that receipt of TCM. And then we tried to follow those groups as long as we could within this study period to ascertain what those outcomes would be. So compared to the TAC study, how does this differ? So we believe that the TAC study population is largely contained within our population. The TAC work group study really focused on the monetary value of TCM, and we chose to expand that analysis that they had already looked at to see if those differences persist over time. And we also wanted to examine other value-added parts of TCM that the TAC study did not address, but would say would be interesting areas of future research. We wanted to see how close to those we could get. So some strengths of our design in this, we did allow that longer period of time, which allowed time for more outcomes to occur. Sometimes things don't happen instantaneously. They happen it happens to take a while for them to appear in our data. We wanted to give enough time to allow those things to happen. We also really wanted to do a deeper examination into some of those social determinants of health that we know are vital for this population. We also wanted to expand the time to look at those health expenses to see if it persists, and we really wanted to understand the patient population that were using these services. And then we also established that comparison group to compare individuals that were using targeted case management to those who weren't, and see how their differences compared and how their courses of life compared based on the receipt of that service. So some limitations. We know our MCOs are so great about having different programs in place and care management for different individuals in the population. If there are MCO programs that account for SMI in these populations, we didn't have any information on that in our claims data. And so that information may be missing from this analysis. We also note that several of the variables we have used in our analyses may be imperfect indicators. There may be things that may be imperfectly classified. There may be things that just may have some general errors. That's always kind of a risk of these types of analyses. And we also wanted to note that we didn't have any way to observe care that was received outside of services that were paid for by Medicaid, such as through grant programs or charity care or something of that nature. So population demographics, just to give us a little more understanding of our whole population of TCM users. On the whole, between 2017 and 2021, we found 23,863 individuals that had received targeted case management. Out of our population of people with serious mental illness that totaled around 170,000 individuals during this time period. That means that approximately 14% of TCM users would receive one of these services during that time. What we found was that the group that received targeted case management had slightly more persons who were identified as Black than the group that did not receive TCM. They were also slightly more non-Hispanic than the group that did not receive TCM. And they had slightly more people who identified as female than the group that did not receive TCM. Interestingly, both groups were functionally of similar age to one another. I believe the mean age was around 31 years old. And the group that received TCM lived in slightly more non-metropolitan areas than the group that did not receive TCM. On average, TCM recipients received about 10 months of TCM services. And so that's the time between first use of TCM to last use of TCM was about 10 months. And we see from our graph below showing the distribution of that it's heavily pushed toward the left side, showing that it's in those much lower numbers as the most common facets of use. Within those 10 months, TCM recipients have an average of 8 claims for TCM services. And again, we see that left skew in the chart indicating that it's majority in those lower numbers of claims for this service. To kind of quantify that a little more, around 58% of people who received TCM had 5 or fewer claims for TCM services. Around 4,600 or 26% of individuals that received TCM had between 6 and 10 claims, and only about 5,500 or 23% of TCM users had more than 10 claims for TCM. So we also wanted to look at all expenditures and look at the monetary over time and by year. And so this is a rather overwhelming chart. Overall, between 2017 and 2021, TCM users' expenses approximated $6.6 billion during this time period. And the largest absorber of those expenses were WellCare, our fee-for-service population, and also Passport by Molina. And here's a chart kind of showing those differences over time. You'll notice that absent from this chart is United. We only had one data point for United during this time period because of when United came on board. It takes more than 1 point to make a line, so that's why they're missing from this chart. But we can see, again, that WellCare on top, and we can see kind of this trade-off happening between fee-for-service and Passport by Molina on the expenditures by TCM users. Whenever we look at the expenditures for TCM as overall, however, the total dropped significantly to about 65 million over this time period, with again, the vast majority being absorbed by WellCare and next by Passport by Molina. And what this means compared to those prior numbers that we looked at is that TCM accounts for roughly only 1% of all expenditures annually across all MCOs for users of the service. So here it is, looking at it again over time, we again see that WellCare had a rather large spike occur after 2019. We can see pretty steady expenditures for fee-for-service on TCM use. And we can see a little more growth over time for the rest of our MCOs, but again, a large spike in WellCare beyond that time period.
Kaylin, hi, this is Lisa Lee. Thank you for going through this wonderful. We do have a question in the chat, and I think if we address it before we move on, that way it'd be great. Marcy has asked if she heard correctly that targeted case management is 1% of expenditures, and that's what you said. So it is 1% of overall expenditures for the population, correct?
Yes.
That received TCM.
Yes, that of just that received TCM, it's about 1% of the expenditures each year. I found that number by approximating each of these numbers against each of these grand totals from the previous years. And it equated to roughly 1%-ish. There may be some years where it was a little more, there may be some years where it was a little less, but it's centered around the 1% number.
And so the previous expenditures included all services that individuals who received targeted case management were also receiving. So it could include hospitals, physician services, that sort of thing. And it also includes targeted case management. And the second chart is costs for targeted case management alone. So,
Yes.
okay.
Yes, that is absolutely right.
Thank you. We've answered the
Mhm.
question.
Middle, we can get into some of the more analytical findings. So the first thing we really wanted to look at that we knew from the literature and just from speaking with people was homelessness. We were able to identify about 9.7% of our TCM users as being homeless. And that was compared to about 5.8% among those who did not receive targeted case management. We did some statistical analysis and we found that targeted case management users had about 1.8 times increased odds of being homeless compared to those that did not receive targeted case management. And when we adjusted our statistical model for someone's age, how sick they happen to be, their race, their ethnicity, and their sex, the odds remained elevated at around 1.8 times the odds of a person that did not receive TCM being homeless. Also important to us was looking at non-emergency medical transport, and we found that about twice the frequency of users of NEMT among TCM users compared to non-TCM users. So it's about 34% among those who received TCM ever used NEMT, compared to about 16% of non-TCM users that ever used NEMT. Again, we did some statistical analysis and we found that TCM users had about 2.7 times increased odds of using NEMT compared to those that did not receive TCM. And again, we adjusted our statistical analysis again for age, how sick someone is, their race, their ethnicity, their sex, whether they were homeless, and their metropolitan status. And we still found those elevated odds that equated to about 2.7 times increased. Also important to look at for us was long-acting injectable antipsychotic use, because we know that these are really important measures. And we did find a significant increase in the number of TCM users that were identified as using a long-acting injectable compared to non-TCM users. And that's about 1% compared to 2.7%. So again, with our statistical analysis, we found that this was a 3.1 times increased odds of someone that had used TCM using a long-acting injectable compared to those that did not receive targeted case management. And again, we adjusted this for age, how sick someone was, their race, their ethnicity, their sex, metropolitan status, homelessness, and whether they used NEMT. And again, we found those increased odds of about 2.6 times, even accounting for all of those things in the background. Mortality was also something that was really important for us to look at. And overall, we found that 4.3% of individuals with SMI were identified as having died during our study period. And this is roughly similar to what it is in our general Medicaid population. However, whenever we stratified this out, we found that it was only 3.6% of individuals that had used TCM died, compared to 4.5% of those who did not receive TCM. So again, we did our statistical analysis and we found a 20% decreased odds of mortality among those that used targeted case management compared to those who did not. And again, when we adjusted this for someone's age, how sick they were, their race, their ethnicity, and their sex, we found 18% decreased odds of mortality in our population of TCM users compared to those that did not receive TCM. And we wanted to break this down and look at it a little more over the entire study period. Again, our 2021 numbers, they're a little bit of a washout number here. It's kind of like a grand accumulation from all of the other years just with how we did the analysis. But we see across all years, there is largely an increased mortality rate among our population with serious mental illness compared to the rest of the Medicaid population in the state for mortality. So getting into the expenditures, we wanted to look at these over time, and what we found was that on average over this 5-year period, beneficiaries that received targeted case management spent approximately $2,000 more per person per year than individuals who did not receive targeted case management. And over a 5-year period, those differences did seem to decrease over time. When accounting for age, sex, and metropolitan status, those differences diminished over time even further, even though they remained a little elevated over the other population for the duration of that 5-year period. What was interesting to note for both the behavioral health expenditures and the medical health expenditures, which we'll cover next, in both cases, there was a spike after 5 years for individuals with SMI that received TCM in those expenditures. And what we believed that was thinking about the general time period. If you made it 5 years into the study, you were enrolled in 2017, you made it all the way through 2021. And at that 5-year mark, it was the post-COVID period when all of the prior authorizations had been turned off and there was pent-up demand for services. And so we believed that's what that spike after 5 years was really showing, was all of that pent-up need from COVID and the removal of the prior authorization. So that was what we believed explained that one. As far as medical expenditures, beneficiaries receiving TCM spent approximately $3,500 more per person per year than individuals who did not receive TCM. And over a 5-year period, again, those differences did seem to remain consistently increased over their non-TCM counterparts. But whenever we account for someone's age, how sick they are, their sex, and their metropolitan status, still it remains slightly more increased over time. And again, we saw that 5-year spike in this analysis that we believe was attributed to the removal of those prior authorizations and pent-up demands from the pandemic after this time period. So we really wanted to understand why we were seeing these increases in expenditures. And so we looked at several different outcomes of interest for this population. And we found that actually individuals with TCM compared to those that did not receive TCM had fewer hospitalizations, but they had more behavioral health ED visits, more medical ED visits, more outpatient primary care visits, and more preventative services compared to that other population. So kind of wrapping this up and putting it all together and kind of understanding what it all means. The population that received TCM were more likely to use non-emergency medical transportation. They were more likely to be homeless, more likely to use long-acting injectable antipsychotics, and were less likely to die during the study period. Like the TAC study, we also showed those increased expenditures over time for the group that received TCM. But what we found in return for that was that there seemed to be more utilization of healthcare services than the group that did not receive TCM. And so this may not necessarily be an indicator of a bad thing to say. It may actually be a good thing that they may be using these services because it means they have someone looking out for them during this time period. Our data really couldn't speak to a motivation or kind of moralizing whether these services should or should not have been used, but kind of taking into consideration, it may not necessarily be a bad thing that they're utilizing more services. And that is the end of our data presentation. I'm happy to take any questions.
Thank you so
Kayla?
much, Dr. Connor. I think there were, I think Dr. James had a question in the chat. Tom, do you want to ask that question about the confidence intervals?
Yes, one of the things about confidence intervals is it helps to differentiate the kinds of treatments going on within TCM. And are there best practices that we can glean from that?
Yeah, so the confidence intervals, admittedly, from this analysis, we didn't look at a lot of those directly, admittedly. That could be something we could go back and look at. I will tell you that our p-values were generally very, very small, which usually equates to a very narrow confidence interval. Whenever you're dealing with a population of about 170,000, that's going to make your confidence intervals pretty tight out of hand if something is significant. So, yeah, one of the things that I really wanted to include in lieu of that was kind of showing those means to allow someone to kind of make a judgment call as to whether there was any clinical meaningfulness in some of those analyses. Be happy to look into that more for you, though, if there's anything you'd specifically like to be looking at.
Maybe it's the baseline disease entities that were in the two different groups, which may impact some of that health outcome or healthcare resource utilization. It could be not related to TCM, but related to what's physiologically going on.
Definitely. I will say that one way we did try to look at that, I mentioned that we had a measure of how sick an individual was. We used a Charlson Comorbidity Index, which was a ranked score from 0 to 36 based on different physical health diagnoses found in those populations of interest. I believe the maximum score in both of our groups was an 18 out of 36. So comparably, they looked rather the same on those Charlson comorbidity indices, but I definitely see your point there about the different overall.
Right. And Charleston's got a low R square.
Yes, very much so.
Okay, thank you.
Thank you so much, Dr. Connor. I wonder if there are any other questions. I think Margaret had asked about the fee for service, and Commissioner Lee had responded that there are folks with SMI that are in waiver programs or in long-term care and receive Medicaid benefits, so they would have been included. Is that right, Commissioner?
That's correct, Dr. Schuster. We do have our 1915C home and community-based waivers and our long-term care members who have also, most of those are in the home and community-based waivers. But it's more, the targeted case management is a little bit more intense than the case management that those individuals might receive through their waiver program.
Right. Can we take the screen share off, please? Kelly, thank you. Yeah, it'd be good to see people. Thank you. Any other questions from anyone? We will send out the PowerPoint. I'm wondering, Commissioner Lee, if you would like to opine on what you heard from this, the combination of the BH TAC study and then this.
So thank you, Dr. Schuster. I think the first thing I would like to do is just thank you all for looking into this information and looking into the data and trying to ascertain what is happening when individuals get targeted case management. And I think what I heard is that it keeps people out of the ER and that they can navigate, they are given assistance in navigating the healthcare services specifically for them, which I believe that's a good thing. It means that they're getting the appropriate services in the appropriate location rather than going to the emergency room. I also heard that individuals receiving targeted case management are less likely to die, that they live a little bit longer. So I think those are some of the things that you were hoping to see with the result in the study of targeted case management. And yeah, I think this is just the tip of the iceberg on some of the things that we can look at. I think definitely continuing to explore, policies around targeted case management and other services in the behavioral health arena are definitely going to help us drive positive policy decisions as we move forward. And I would like to ask if Deputy Commissioner Hoffman would like to weigh in on any of the study. And I think that Oda has done a good job, and the teamwork in this was very valuable as we move forward with these with the reports. Deputy Commissioner Hoffman, did you have anything?
I
to
was
add?
just going to say, what a wonderful opportunity for these groups to work together. We did, it was just a really good collaboration from sister agencies and OHDA and the TAC, and with a good outcome that we can utilize, something we can utilize to drive policy. So I appreciate that.
Well, we certainly appreciated the easy working relationship that we had with the, particularly the DMS data people, because we were really, we started out wanting the moon, I think would be safe to say, and then they were so helpful in helping us winnow it down, and they asked such good questions that it really helped us to focus. I wonder, Alan Renzel, I see that you're back on. Do you have any comments about the data as you've seen it here?
I do not. I think it's a complex issue. And again, I think, depending on what your overall goals are, there's more that could be done. But I think one of the initial issues around overall cost, and it's hard to know what the right answer is, because when you engage people and you get them in targeted case management, and they get their routine health care, and they get their colonoscopy, and they get their that's a good thing. What we had hoped to see is a decrease in ED utilization, right, in terms of getting people into appropriate services rather than emergency departments. But it's very hard to break that down. There's lack of continuity in this population. Capturing folks who got consistent amounts and months of services was challenging. Folks go in the hospital, they come out of the hospital. But I think that overall, I think this did show that there's substantial value in the service. Granted that it could always be improved, and that we need to look at fidelity and who's getting what kind of services. But it was a Herculean effort, and do appreciate the collaboration with the Medicaid data folks.
And Steve Shannon or Kathy Dobbins, you were on the home team, so to speak.
I'm
Steve?
going to give the message I've given throughout, that sometimes the ER is the right place for people to be. And we've never really able to segment that out, that in a real emergency, that's where they should be. I just like to remind people of that. So not every ER visit's inappropriate. Some are appropriate. We just want to make sure. But, I was encouraged again that people are accessing care, and that's really what needs to happen. And that's beneficial. And if you access care, you're going to be in a better place. The thought process we all have. So I'm glad that our initial little work, that wasn't profound, led to much more significant work and much more science than we ever added, right, Sheila?
Yes.
I mean, considering the population, with mental illness like myself, if the statistics say that we die 25 years younger than people who don't have mental illness, anything we can do to extend our lives is very, very helpful, so there you go.
Absolutely. Extending people's lives and fewer, I believe we saw that there were fewer, or there was greater use of non-emergency medical transportation, which would suggest the supportive services are helping to link people to non-emergency transportation, which is less costly. And I think I believe we saw that there were fewer hospitalizations or less cost in hospitalizations, which seems like a very big plus. But definitely, to see the people who are getting service are living longer is.
I'm all right. I'm watching the behavioral health TAC.
Could you mute, please? Thank you. Go ahead, Kathy.
Well, no, that's all. Just really kind of echoing what Val said. If TCM is able to impact life expectancy in a positive way, that to me is enormously important to recognize. And yeah, I mean, that says it all, really.
Yeah, I was disappointed about the homelessness. And the two things that we weren't sure that we could really get a handle on. And I guess I would ask you, Dr. Connor, and we may have talked about this when you first gave us the PowerPoint. How did you find out who was homeless and who was not? Do I remember that?
I believe we did discuss this, but I'm happy to give more information on that. And whenever I start failing on my technical knowledge here, I know one of the main data analysts that helped us with this, Patrick Perry, is also on the call. So he can fill in anywhere that I have gone completely off base here. But we used our IEES system and our Medicaid system, so our integrated eligibility and enrollment system, which is the data source that's used to track eligibility and enrollment for the Medicaid program. And that data did have an indicator or a way to identify a person as being eligible because they were homeless. So it was someone who had ever identified as having a living arrangement of HL, which meant homeless and or living in a shelter of some type. And again, it has some questions associated with it. It may not necessarily be the best. We may be undercounting in a lot of ways, but we wanted to really use it as an approximation for the population's outcomes. We didn't necessarily want to use it as like a flag to identify the persons themselves. So kind of knowing that that statistic has a little bit of murk and mud around it. Again, it was just an approximation. We believe it is a pretty good approximation based on Medicaid's enrollment system, but it is an approximation nonetheless in that regard.
So
Well,
Sheila, that didn't surprise me that we would see a higher percentage of people who are homeless who are getting the service, because those are folks who have really high needs. If that's when they come into.
Well, that's true. That's
Yeah.
true. I was thinking of the end result being hopefully the targeted case management got them into some more permanent housing. So you're right. You're exactly right. So the people that are homeless are the ones that with the greatest need for targeted case management.
And I guess, Caleb, based on what you were just saying, we couldn't really see if their housing status or homelessness status changed over the time they were getting TCM. Was that right? So we hope it did, but you weren't able to identify that. I don't think, but correct me if I'm wrong.
I'm going to actually defer to one of our analysts on that one. I'm not entirely certain on how that looks. Patrick, do you have a good answer for that one?
Yes, ma'am. Dr. Connor, this is Patrick Perry, statistician with ODA. The homeless indicator from IES was taken as documented at least one time as homeless within our study window. And that was the only way that we took it as an indicator. So it was a dichotomous variable. So we did not follow if individuals remained homeless, their housing status changed or anything like that. It is if they, during their TCM journey, during our study window, had ever indicated as homeless.
Yeah, so thank you so much. That really makes sense. So that's a one-time indicator. And I think you're right, Kathy. You all are identifying, providers are identifying the people that are most in need of targeted case management, and the people that are homeless would be in that category. I guess the other piece that we toyed with and we couldn't figure out a way to do it, we would have to go to the administrative office of the courts, and that is to look at, is there any difference in those two populations that you have, Dr. Connor, in terms of with targeted case management and without, in terms of their contacts with the criminal justice system. And we really, that was not, we couldn't figure out how to do it. That's not Medicaid data, obviously. And you all didn't have that as well. But that would be the other piece of this study that would be really, really helpful to get a handle on. I think it would be the outcome in terms of homelessness, and then it would also be that, interface with the criminal justice system. So anybody else have anything else? We're so grateful to the folks at Data Analytics, and Dr. Connor has been very patient with us the first time around and the second time around. It certainly took our little study, although our study, I think, was right in line, actually. I mean, we had the right idea in terms of a time sampling. I love it that yours is over a longer period of time, because I think it gives greater weight to those variables, and you were able to, look at more people and do that, linked study with the with TCM and without TCM. So that's great. And Matthew's saying APRIS has the incarceration criminal justice data. Yeah, that might be worth going back and looking at some point. So we appreciate so much your presenting, and we will send that PowerPoint out to everyone that is on our list. We'll make sure that gets out to you. And thank you so much for being with us, and your colleagues as well.
Thank you all so much. It was a joy.
Thank you. Commissioner Lee, I know you have to leave us shortly. Any other data studies that you have in mind for us to do now that we have figured out a little bit how to do these things?
Yeah, I was going to say, what are the next steps now with, with the data? Is there anything that we can use here? And I just think it's up to the behavioral health TAC to try to determine what they want to look at, what data, what reports you think would be useful. Now that you know the system and that what sort of data we have and how we can use it. So anything that this committee is interested in looking further into, any sorts of specific procedure codes or services or even regional differences. I mean, that's the other thing I think with the targeted case management, always looking at regional differences. Is it being promoted or utilized more often in one area than another? May get back to some of those best practices, which providers seem to be delivering the services more often and who seem to be getting results, and what can we learn from them, and what we like for them to come and speak to this committee.
Yeah, that's excellent. And we will certainly take a look. I think people will want to look at the data and have a chance to really dive into the figures and so forth. So let's put that on our agenda for our May meeting to kind of come back and look at that. Appreciate that invitation. So appreciate your making the EMS folks and then the data analytic folks available to us, because it certainly helped us in laying out our study.
We're definitely your partners, and believe that this TAC, the members of this TAC, have the expertise to know what to look at to help drive those policy changes. So we definitely will work side by side with you as we move forward, trying to figure out what exactly we need to look at that would help us drive some policy. And I know that we have the annual report, the 2020. It's a little bit dated, but this committee could look at that report, and I think you can see that some of the major or top diagnosis and procedure codes that are outlined in that annual report do relate to behavioral health. We do hope to update those reports here in the next few months to give a 2021 and 2022 report. And if we continue to see those same trends as behavioral health being one of those top diagnosis codes, and what do we need to look at as far as workforce and maybe providers in the community, or anything that we can do to promote the use of behavioral health services within our population and our provider community.
Yes, and you presented that annual report to a number of legislative committees, so we need to get that out as well to the TAC members.
Yeah.
So
and
we
plan on posting that online too. So we'll send out a link as soon as we post that online.
Wonderful, thank you so much. While you're still on, I want to bring up this next item because it has been the source of great angst among some of the providers. And that is that the billing codes for extended length of behavioral health service sessions has been done away with, as best I can tell. This was a recommendation made by the AMA group to CMS and really caught people by surprise. Bart Baldwin brought it to our attention under new business in our January meeting, and there's been quite an exchange of information. But no real solutions. And I'm wondering if, and maybe Leslie, this question to you, or Commissioner Lee, about what you all have looked at and where you are with this.
Yeah, we have been having lots of internal discussions. We have reached out to our colleagues in other states to see how they're handling this. We're getting a few little responses in, but I think Leslie and her team have been working on this topic specifically. So Deputy Commissioner Hoffman, you want to weigh in on this?
I was just going to mention that Sheila, when we spoke before, I said communication was forthcoming, and because it hasn't come out yet is actually a benefit to the providers, because we decided to stop what we were doing and take the time to do the research with other states and look at the coding guidelines and how are other states addressing the same, because it's not just Kentucky, it's everywhere. So we wanted to take that time. We have come up with a couple proposals, and we have a meeting on the 17th to discuss that internally. So I just wanted to let you know, it's not that we didn't send out the communication. We decided to take a deeper dive into research with the other states.
So when you say that you all are meeting, and I assume that that's an internal meeting in terms of if there's anything that you might be able to recommend for providers?
Yeah, if you can, so our meeting's on the 17th. So let us get through that meeting. I want internally our executive leadership to take a look at a couple of proposals that our behavioral health team has come up with, if that's okay, Sheila.
Okay. I know that we're hearing from, quite a range of providers about what difficulty this is creating, particularly for people with really significant behavioral health needs. And apparently we got a little bit of hint from some national groups that, they're aware of it, but nobody's quite weighed in yet to see if something might be proposed at the national level. Are you hearing that as well, Leslie? Or
I'm hearing from other states having the same issue. So I'm guessing that the national level is hearing from the other states as well. So I do think it's good that we tried to stop a second though, and try to do some research about some other proposals we might be able to come up with.
Yes. So let me ask you, and I ask this only because, this TAC won't meet again until May, whatever it is, 9th maybe. If there might be some communication back to me that I might be able to share with people at whatever point after you all meet on the 17th, if you have recommendations or at least some information that I might be able to share.
Sure. I don't mind at all.
Okay.
We understand the importance of this issue, Sheila, Dr. Schuster, and we'll definitely get information out just as soon as we can. And we hope, very shortly after their meeting on the 17th to have some sort of solution.
All right, that would be super, because again, there really are, I think partly what's happening is that providers are running into this, it takes a while for it to kind of filter down, and maybe people haven't encountered it quite as early as it came up in our January meeting, but more providers are coming forward and saying this is truly a problem, and it's across age groups, of course, in terms of what the needs are. So I appreciate that, and I will be on the lookout. And as an Irish woman, since you're meeting on St. Patrick's Day, I'm going to hope you have good luck in coming up with some workaround or alternative or something like that. Does anybody have any other additional questions about this topic? All right, then we'll go on to the next thing. And I don't know if Justin Derringer is on. We were looking for something that was going to be posted on the website about reporting patient no-show data. And I have not seen, I actually have not been on the website to look. Is that up yet?
This is Justin Derringer. No, unfortunately not. We are still working on that. I'm checking on it each week to make sure that it's being worked on, and it's just not quite ready. I think it was a little more complicated than they thought it was going to be, but we are working on that and checking on it each week, so it should be up very soon.
All right. So Justin, you have my email address. Do you mind letting me know when it gets posted?
Absolutely. I will send that to you, send you the link, and we will be sending that to a lot of different providers.
Yes, I'm sure.
And-
I'm sure you will, because there's a lot of interest in it, and I think it could be a really helpful tool for our members, actually, is what I'm thinking about, but particularly people with behavioral health issues who maybe are not navigating problems that come up that are really social determinants of health, transportation, childcare, those kinds of things. And it just adds to their angst and they just don't get to appointments. So I appreciate that, Justin. I appreciate your working on that. So we will look for that. Thank you.
You're welcome. Yes, ma'am.
I understand that there's been some movement on the creation of a uniform bypass list by the MCOs for the dual eligibles on the commercial side.
That's correct.
Who's answering that, please?
This is Herb with Humana.
Herb with Humana. Great. I was going to call you out because Steve Shannon told me you were the guy, Herb. So
That's
this
fine.
is great. This is great news, Herb Ellis. Tell me about it.
Sure. It's a collaboration with the department and with the other MCOs to streamline the process on being able to process claims primary under Medicaid that we know have services that are not typically covered by the commercial plans. And so, right now we require, based on the department's policy, a remittance that shows that you all did some kind of a due diligence review with the primary coverage when it's commercial before being processed as secondary under the Kentucky Medicaid program. This bypass list has, I believe, about 82 procedure codes and 3 modifiers that if the claim contains just those codes or just those modifiers, we will not require remittance. It'll just automatically pay as primary under the Medicaid program, very similar to the Medicare bypass process. Biggest difference is that we don't take into account provider type codes. So we're not going to look at your diagnosis codes. We're not going to look at your provider type codes, your taxonomies. It's strictly based on these specific procedure codes and the 3 modifiers. And we're targeting a 5/1/2023 go live. That's for all the MCOs. And as of last Friday, we're all still on target for that. The department did give us a green light to move forward on that bypass list. We also built into the process the ability to utilize a streamlined and centralized attestation form. It's similar to one that WellCare's had in place for a while now, but all the MCOs agreed to use the same attestation form. And that's basically there for those situations when the primary commercial carrier will not issue a remittance. Then you can complete the attestation form that shows that you did your due diligence to try to get a coverage analysis from that primary commercial insurance company. And you can attach that to the claim when the codes on the claim are not on the bypass list. So that's what that attestation form is for. Outside of the attestation form and the commercial bypass, everything else is a standard procedure for, remittances that we receive and we'll process secondary to the remittance.
Wow, that sounds fabulous. This is one that Steve Shannon and I, our typical thing is we've been working on this for 20 years. This sounds great. Let me see if anyone has any questions. Well, let me see if I've got this so I can put it in the minutes. So basically going live on May 1st of this year will be a list agreed to by all the MCOs and in coordination with DMS of 82 procedure codes and 3 modifiers. So that if those are the codes that are on the claim, they should go through without any additional paperwork or attestation or proof that you've done your due diligence and gotten a rejection by a commercial insurer if the patient is covered by both Medicaid and a commercial insurer. And
let me just, it's actually 88. So I misspoke. 88 procedure codes and 3 modifiers. And the 3 modifiers are TD, U5, and U6. And then there's like I said, there's 88 modifiers and, or sorry, 88 codes. And basically we took the BH fee schedule, and it's the BH fee schedule that we then used across all the 6 MCOs to compare to our internal commercial plans, and then looked at the utilization rate and cost tied to those codes. And anything that fell below 10% coverage is what we then put in as an acceptable code to bypass. We'll still do pay and chase for the department that might be interested, for those codes that we did see some coverage across our commercial plans, but it was just very low. We'll still do our own pay and chase with those with those commercial plans. We just won't be going after the providers for it.
Great. And then in the case where you have a code that's not on that list, you all have agreed to use the same consistent attestation form that a provider can fill out and send in with their billing.
If you can't get a remittance.
If you can't get a remittance.
Yeah. That's what that attestation is only for, that rare scenario. And we haven't yet found one, but we've heard that there are apparently some commercial plans out there that won't even issue a remittance on certain codes if the codes are not covered. So if that ever happens, that's what the attestations form is for. But otherwise, we would expect to see a remittance.
Yeah. Okay.
Yeah. And we also have a process where any other codes outside of the 88 that we've talked about in the 3 modifiers, if there's other codes that the providers or even the agency for the BH providers are interested in the MCOs taking a look at to see what utilization costs and rates are across the plans, we'll entertain those as well. And so this is not like, this is a living, breathing document, if you will.
Yeah. Wonderful. We so appreciate the MCOs coming together and working on this. Let me see if there are any questions of anyone who's on the Zoom, any providers that have any questions for Herb. I can't see you, so you're just gonna have to speak up if you have a question. Yeah, Kathy Dobbins says, would you make the 88 procedure codes available to this TAC group?
Sure, I can share that. I know I shared it with Steve, and I can share that with you all.
Okay, great. Yes, that would be great.
This is a big deal, really. Right?
Yeah.
And we've talked about this for a long time, and we appreciate the leadership of Herb Ellis and his MCO partners to get us to this place. So, we're excited about that.
Well, we're really excited, Herb, to be able to take off this agenda item for dual eligibles, which
Yeah.
we've had on there for months and months and months and months, years and years. So thank you to you and to your counterparts at all the other MCOs. We really appreciate that. And I will look for you to send me the list, and I will get it out to folks.
Absolutely will. One question no one has asked yet, but it's for dates of service 5/1 in 2023, just as an FYI.
It's for dates of service starting 5/1/23 and going.
That's
forward.
correct.
Yeah.
That's correct.
Okay. All right, that makes sense. All right, wonderful.
This is Paula from WellCare, and I was just wanting to make sure people did try to get the attestation, even if it was a code on the list, so that they have their own proof if they are audited. I want to make sure people understand that it's important to build a primary.
Yep. And Steve, we talked about that, right? That until such time and or if the department decides to change their policy, they still have that due diligence review that's required by the providers to go to the primary insurances for coverage. I know that's an open issue or open question with the department for review to see if they'd be willing to, accept an attestation and keep it on file for a year. But at this point, we haven't seen a decision. So right now, that's the current state's policy.
And then another question from our operations VP, Rebecca Randall, is is there a communication plan that DMS is going to provide this to providers, or how are we going to work through that? I mean, we can do it through TAC meetings, of course, and our other meetings, like the CMHC meetings.
Agreed. Yeah, and that is also an open issue with KDMS for review as well. We, as you know, we did create the MCO version as well for the provider outreach in case the departments decided to default back to the MCOs. But we do believe it'd be best interest to have just one notice go out to the providers and hopefully from the department versus the 6 that they would see.
Leslie or someone from DMS, can you respond to that, please?
As far as sharing with other folks.
Yeah, I mean, no,
we'll probably,
yes.
yeah, we can run that through our communication. We can put it on websites, banners, or anything like that we need to. Jonathan's also covers most of the listservs.
So I guess what we're asking is DMS going to take responsibility for getting it out to the providers as opposed to each of the MCOs getting it out to their providers?
I think that's fine since it's a request of the TAC.
Okay, great.
And I'm willing to share that draft doc. We created a draft for the department to use if they're interested in it.
Okay. Thank you, Herb.
I'll if you want, I can share that to the stack as well. It's not.
Yeah, I'm open to whatever we need to do to get the word out. So,
Perfect.
yeah, you and I can work on that outside of here and then report back to Sheila.
Yes, ma'am.
Yeah, that would be wonderful. Thank you so much. Wow. So Kathy Adams is saying, how will the DMS communication be issued? And I think that's what Herb and Leslie are going to talk about, and then they will let me know what the plan is.
That's correct.
Okay, thank you. Wonderful. Our undying gratitude, Herb and the MCOs. I'm so glad to check some things off the agenda. Leslie, you're up on status update on the waiver for SUD services, SMI waiver, the request for extension for Team Kentucky, and all of those things.
Yeah, I've made some notes here because I didn't want to leave anything out, Sheila, so just bear with me. So on the incarceration amendment, CMS reached out to, I think there was 12 states on a call that all had some form of amendments, 1115 amendments related to incarceration, and they varied a lot. CMS, mentioned on the call that Kentucky is very unique. We have a really robust relationship with sister agencies and with a Department of Corrections as well to help provide some of those services. Our amendment was for SUD, where California's was recently approved. It's for all populations as well as juvenile justice, and they have a 90-day post-release coverage. So it's a little bit different than ours. So we were specific, like I said, to SUD, and then we have a 30-day post-release. And then we also want to cover pretrial because in Kentucky, lots of folks sit for a long period of time without anything. So we want to make sure that we can catch those pretrial folks as well. That day, we did ask for CMS to have a one-off meeting with Kentucky. We still do believe we're first in line to have those conversations, even though California was approved first. They said that there will be additional guidance that's coming out in the state Medicaid director's letter very soon, and suggested that we not make any substantive changes to the amendments. Any of the 12 states make substantive changes to what they currently have in with CMS. So I think what they were getting at is let's try to get approved what we've got now with them. They mentioned that they had over 55 1115s to review, and they weren't going to get to all of them before the end of the year. So they were very pleasing to work with. And I reached out again today and asked for our one-off meeting. So as soon as I get additional information on the incarceration amendment, I'll let you know. As you're aware too, we've got a couple of bills as well as the Omnibus Act that we're now looking at for juvenile justice. So that's forthcoming as well too. Our overarching Team Kentucky 1115 is still with CMS, and we're waiting for feedback. We do still meet with them every month, but we do not have feedback on the overarching 1115 yet. And that of course included SUD, NEMT pieces that you're aware of, there's a piece for former foster care and a piece for employee sponsored insurance. So there's a couple little pieces that go in into that big Team Kentucky 1115. Our SMI 1115 amendment is expanding, so I wanted to explain that to you. We've mentioned that the SMI amendment is expected to move to public comment period sometime in spring. We did submit a draft to CMS, I think, the last week of December, but we are now having a companion waiver to that one, and they will work in conjunction together to fill in the gaps that we have here in Kentucky. So we'll have a 1915I as well as the 1115 amendment. And I know that's a lot of numbers and a lot of acronyms. Basically, what we're trying to do is to encompass, Sheila, all the needs of the Kentucky members, from the institutional level of care all the way up to folks who just need the pre-tenancy housing and maybe some supported employment and other community things like that. So our 1915I is currently in development we're doing the current research, state research, the targeting interviews, which I think Dr. Schuster, you and Steve have participated in maybe at least one of the interviews.
Right.
Those are going well, and to align with the other existing HCBS benefits. We hope to have the analysis and the draft completed mid to late summer, conduct the town hall sessions like we normally would, post for public comment, and finalize and submit the 1915I. The public comment would be sometime around, again, mid to late summer. So we'll keep you involved. And I always try to meet with you and several of the other advocates just to let you all know where we are in our behavioral health solutions for Kentucky. So
Right, thank you.
Questions?
Yeah, does anybody have any questions? So there's movement on all of those pieces. I think I see where Brenda Benson is on, and I know the question comes up all the time about the SMI waiver for supported housing and supported employment. And I think that adding that 1915I piece to the 1115 amendment piece makes sense. So we were pleased to be on the, have the interview and so forth going forward. Thank you for that. Mary Haas, update on therapy service access for individuals on the ABI waiver.
Unfortunately, we're still in limbo. The latest that I had heard is that the therapies are still in the waiver. We have not gotten any indication that has went to the extended state plan. My biggest concern is we had a meeting back probably 2, maybe 3 months ago that we were going to start talking about transitioning because we're losing a lot of our skilled therapists. I've got notes from 2 people because we had a 1915C waiver day yesterday at the Capitol. And one of the concerns that several of the providers brought to me was that they're losing their skilled therapists. On another note, one of the providers came to me and said that their local hospital asked them to do cognitive therapy, cognitive rehab therapy with some of their patients in the hospital. And so that was good news, but the bad news is that we're losing those skilled speech therapists who usually takes the lead on the cognitive rehab, cognitive therapy, whichever way you want to say it. So anyway, so right now the therapies are still in the waivers, and I think we're just waiting for CMS. The latest I heard now was probably July. Leslie might be able to give a better update, but that was the latest I heard. And then when I seen Pam Smith yesterday, she told me we now do have a waiting list for the ABI long-term care waiver. So we still don't have a waiting list on the acute. I don't know if there's something that can be worked out with someone who possibly is waiting on the long-term care. so I don't know, but right now, to answer your question, we're still in limbo.
So I can give some updates. So there, yes, CMS does still have the waivers. They're within their 90-day window. We have not heard anything back from them. And we also, in addition, committed at least once we do get the waivers back, at least a minimum of a 60-day transition period. So we haven't even started even talking about transitioning or doing anything with the therapies. They are completely as they have been. We have not made any changes. On Tuesday, yes, Mary, I did let Mary know on Tuesday when I was over briefly that morning, and I was thankful to be included in the 1915C waiver day, that we do have a wait list for ABI long-term care. The new waiver year will not begin again until July. What we are doing until that point, it's less than 10 individuals. I think we're at either 5 or 7. I have the staff actually evaluating them. 2, if not 3, are actually still receiving services on the acute waiver. There were a couple that were receiving services in HCB, but what our plan is, because we have a sufficient number of acute slots, is to serve those individuals on the acute waiver until we have the slots. We, turn over the waiver year in July, and we'll have slots open again, and then we can transition those individuals. They would be the first ones that would be able then to transition into those open slots on the long-term care. But it is our intent to get them services, if they're not already receiving services through acute, to get them services in the meantime until we have the slot open in long-term care.
So those people, Pam, are going to be served while they're waiting.
Yes, we are. We'll reach
Yeah.
out to the individual. In most cases, it's a case manager that did the assessment for them or help them do that application. We'll reach out to that individual and let them know what's happening and have them help us coordinate with the individual themselves or their family members, so they, don't wonder why they're all of a sudden getting assigned to the acute waiver or what's going on. So there'll be communication with them, but we're working on doing that. We're working on doing that right now.
Okay. So when you say that CMS has the waivers, I'm a little bit confused.
So we had to, both of those waivers were due for renewal last year. They came to the end of their 5-year approval period. And so right now we are functioning on a technical extension. So CMS has those, and they're back on the clock for them, the 90-day clock for them to review the waivers, and then to either issue us another approval, which will give us another 5 years, or until we have to amend them again. Or they will ask us questions. They'll send us back a request for additional information, but they still are within their review period of looking at those applications. But I don't know how, actually, I guess it just naturally happened that all of our waivers between the end of 2021 and somewhere within 2022, every single one of them was due for a 5-year renewal. And it all happens right at the same time. As you know, we're working on things with rates, and where we'll be amending them fairly soon, hopefully by the end of this year. So it's been kind of quite the merry-go-round process of looking at the waivers, changing what we can, submitting it to CMS. So,
right.
But hopefully we will hear soon. And as soon as we hear back, then we'll communicate again. I don't want to, go ahead and we're sending out several communications right now about unwinding and a lot of really important things. And not that this isn't important, it is very important, but I also don't want to send out a deluge of communication and things get lost or people get confused. So we're kind of weighing right now, we're communicating as people come to us with questions. And Mary, if you can, those providers or any of those people that came to you that you feel would be beneficial for us to reach out to and talk to, if you'll send that to me, I'm more than happy to talk to them. But we're trying to balance what the right communication level is, because we don't want to scare people, but we want people to have the right information. But I also don't want I want them to make sure they're able to absorb all the different communication that's coming at them at this time too. So
yeah, what I have communicated to them was 2 contact you is just as I had said, that we're in the limbo period. And but I think the uncertainty, the thing that's causing me heartburn and it's really concerning is that we're losing some of the skilled therapists that have been serving these folks for a long time. And I think it's that uncertainty that, you know, because I know this is, like you said, it's been going on for a fairly good while. And, you know, people, you know, just, they have to make a living, and some, I just can't hang on anymore. That, you know, it's just the uncertainty, and that if they're offered another job, a lot of them are taking it. And I think that's, to me, that's where the concern is just, I think with the providers, and I have said, you know, just as I spoke a while ago, is that it's just, we're in limbo. I don't know. They keep saying we'll win, and I go, I don't know. And so I have said that.
I wish I could give a better answer, but unfortunately, that's that we're at the mercy of CMS right now. So,
and then that's what I've explained to them, is just, you know, right now, I mean, I can't tell them. They ask me when, I go, I don't know. I can't answer that. I have, you know, suggested that they call you, and I don't know if they have or haven't, but that's always been, especially even yesterday, when 2 or 3 of the providers came up to me, you know, and luckily we do appreciate you being there yesterday, because I think that was helpful. I know a couple of the bits of information you gave was very, very, very welcoming. And so anyway, but yeah, it's just that uncertainty. And for me, you know, I've known a lot of these therapists for many years, and it's discerning that, you know, that they're going to lead the field. And especially, you know, when our folks by therapies is how we get better. That's how our folks get better. So anyway, but we'll continue, and I look forward to continuing the process, as I said yesterday, and we'll see what we can do.
Yeah, so both the ABI acute and ABI long-term, they came up at the same time, Pam, for 5-year renewal, and there was CMS, right?
They're staggered a few months apart, but based on just how the whole process has went, one of them, and I'm going to get it backwards. Acute came back to us, has already been back to us for response to questions. And so it's in the second part of the review, and long-term care is just in the first part of the review. So they're kind of in different phases of the review with CMS. We haven't received any requests for additional information on long-term care yet, but the acute is in its, they're reviewing after we responded to questions. So they've had it now for the second time.
Okay. Well, we appreciate your being on and responding. You all may remember that we made that recommendation to the MAC about improved communications. And I usually have, by this time, I've gotten a response from DMS to our recommendation, but I don't believe that I have gotten that yet. So I will share that when I get that. The provider credentialing through KHA and Verisys. And I know that Claire Arendt, who's usually on the TAC meeting, is out of the office, but I don't know if there's any update on that. Did we know?
I haven't heard, this is Dinah Eisner. I haven't heard anything.
You haven't heard anything?
No, I haven't, but I did just text KJ because I knew Claire wasn't there to see if I could get any other update. So if I do, I'll jump back on.
Yeah, thank you. I appreciate that, because we've been waiting. I think we were hoping it might be live maybe last October or so. So hopefully soon. We did have a new business last meeting, questions about an RFP that's going to come out on mobile crisis services in Kentucky. And I think Kelly Gunning raised some questions about, this has always been something that the CMHCs have provided, and, you know, why is this coming up and so forth. And we do appreciate DMS making available a PowerPoint that I sent out to everyone with some of that background. So Leslie, what can you share with us at this point?
So Sheila, if it's okay, I'm just going to give you a short summary about where we are. Again, I can't talk a whole lot today, but I thought I would go ahead and give you just a little bit of the background for those who might not have been involved in the beginning. I've given mobile crisis presentations a lot over the last year. So if you haven't heard one of those presentations in other arenas. So DMS was tasked by the cabinet to develop an all-inclusive mobile crisis model for the state of Kentucky, and anyone would be eligible regardless of age or gender or genetic information or anything like that. Regardless, we want them to be covered for a crisis in the community. We worked extensively with our sister agencies, and we developed some main focuses, and those were to enhance and redefine existing processes, to divert from emergency rooms when unnecessary, Steve. So, and to divert from psychiatric hospitals when unnecessary. We want to divert from incarceration or from confinement, and we want to minimize unnecessary law enforcement involvement, and to acquire the appropriate level of care for the person in crisis, because sometimes that is not what happens. So, those were our main focuses. As you remember, DMS received a mobile crisis planning grant. It was a little over $800,000, and that was for a year, and it ended September the 30th of 2022. One of our major accomplishments was the planning grant, which some of you took part in, not the planning grant, I'm sorry, the needs assessment for Kentucky. And that project took over 3 months, and it was like 250 pages. It is on our website. If anybody wants to take a look at it, I can get that out. We wanted to develop a unique assessment through just talking about boots on the ground, what works, what doesn't work, collaboration, communication, interviews. We did lots of research related to what we currently have and what's working and what's not working, and where the gaps were in Kentucky. So then we used the needs assessment after the grant was over to drive our future plans for our implementation. We're currently looking tentatively for October of 2023. For the implementation. So that's tentative, Sheila. We've also recently applied, for your knowledge, another HRSA grant. It's called a Rural Health Network Development, to help in some of those rural areas that have limited access or limited resources available to them. We are DMS Behavioral Health Initiative is utilizing the mobile crisis as our racial and health equity model. I wanted to mention that because if you've been on other calls with me, I use mobile as my racial and health equity model. It was the first time that we really took like a particular project before we move forward with it, and really went that extra mile to view the project through the lens of racial and health equity and cultural humility. And so we're kind of making that our model. So we continue to work constantly on how to expand the communication, how to reach folks who don't have access or who they don't reach out for access, how to engage those people. So I just wanted to let you know that we can come later, Sheila, if that's okay, and talk again about mobile. But that's where I am right now. We're not doing this to exclude anybody. We are enhancing and refining. So again, I can talk a little bit more about that later if it's okay.
Sheila, may I ask a question of Leslie?
Sure.
Okay, Leslie, when you say mobile and it's open to all populations, would that be someone who would be in the ABI waiver and they have a crisis situation and the person is not wanting to go to the hospital because they actually are not a threat to themselves, but they're a threat to the other individuals in a group home? How would that work?
So we're currently not, we've been working with CMS, we're currently not allowed to go into a Medicaid covered paid service. So like a nursing home either. So I've got staff on too, if I misspeak about anything. We are taking a look at, though, if we can assist with the waiver clients. I've been asked several times about children in the waiver programs. If they're in the Michelle P, they're not necessarily receiving a residential service. So I can let you know more about that later, Mary, but that's an excellent question.
So let me see if I understand your answer, Leslie. You're saying that there's a prohibition against going into any facility that's receiving Medicaid payments?
coverage or payment. Leanne, are you on? Am I
Yes.
stating that correctly? Sorry.
Yes, it's a federal
Reach out
rule
to
through
you.
CMS that the mobile crisis cannot go into an ED or to a hospital facility. Or a facility that's a Medicaid recognized and enrolled facility.
So if somebody's in a nursing home, mobile crisis could not go in.
Correct. CMS says that within that per diem rate within the nursing home, that those services are included. So those, behavioral health services are included in that. Same as with the emergency department. Those behavioral health services should be covered and included within the coverage of the ED. And we do know that that's not always happening. So we are, I speak with CMS about every other day. So with asking questions, and we are working on that. But that is a CMS federal rule.
Okay.
We get asked a lot, Dr. Schuster, about the nursing facilities, elderly population in crisis in a nursing facility, and can we come there and assist? And so far, CMS, that's one of the things that CMS says, no, there's a federal rule around that they should be covering those services. Now, that's not to say we can't figure out, because we're trying our best to figure out, think outside the box of how we can still help folks that are in bad situations, because we know that that's not always happening.
Leslie, what about staff residences? That's a Medicaid facility as well. Would that not be included?
The only one that I've specifically asked about, and Leanne, keep me correct here, was the children who aren't necessarily in the waiver, who aren't receiving a residential component right now.
Correct.
Okay.
Leslie, this is Mary again. The analogy that I gave you, or the snippet that I gave you, was actually someone who would be in an ABI staff residence.
So they as of right now, CMS is saying that if they're in a residential setting, that those services should include the coverage for that member. This is more about I better just hold off and not say anything else until Leanne finishes her questions with CMS, but we're working on it.
Yeah, I think it would be helpful, Leanne, to ask that specific question about a staff residence.
Staff residence, okay.
Yeah, because we know that there are situations that come up between residents in staffed residences that create crisis situations. Would be one example.
Okay, I've got that down.
Yeah, thank you. That would be very helpful. So I may have missed it, Leslie, and I know you can't talk much about the RFP, but what's the timeline on the RFP?
So I can't talk about that.
Oh, you can't even.
We're hoping to implement October of 2023.
I was gonna say, I'll say the same thing that I do. She doesn't look good in orange either, and we like to jail, so.
Yeah, we don't even use those three letters when we're talking about stuff. So yeah, we're hoping to implement 2023 at the program.
Can you answer this question? Has it been released?
Go to procurement jail.
Now I like orange, Steve, but I better not answer that on this call.
Okay.
And I know it sounds like I'm being very glib about it, but it truly is to protect the integrity of the process, because the last thing we want to have happen is somebody to say, well, Pam Smith or Leslie Hoffman said this, and them say, oh, we need to start all over again. So
Right.
Okay, so when you say implementation, you're talking about post award, so that the program is actually rolled out in October.
Through the process, right? And we plan on 90 or more days, Leanne, with working with the community and getting out there and spreading the word.
Yes.
Through the racial and health equity GARE tool, we've also developed communication plans, and we still are continuing to beef that piece up, like how to get into the local community. You've heard me say, I know where to go in my local community here I've got a little small rural community, but I don't know where to go in everybody else's communities. And that's what we want to try to figure out.
Yeah, the very extensive communication plan. I think people are going to get tired of hearing us by the time October comes, because we are going to get, go every nook and cranny in Kentucky to get the communication out.
So one of the questions that has come up, and it came up at the 988 coalition, I'm sorry that Margaret Pennington had to get off the Zoom, was when this PowerPoint was presented there, and this is probably several months ago, and all the 988 crisis call folks, the people that are actually answering those crisis calls, had a million questions about how does this interface with what's going on in answering 988? Because 988 is supposed to be getting those calls and dispatching mobile crisis if that's what's needed.
Right. And Leanne, that it's 988 or 911 if it's just a local call of some of it. So it can go through 911 or it'll go through all the 988s. We're not changing that, right?
Right, correct.
Yeah, I think the question was that those 988 calls are being answered by the community mental health center people.
That's still in the diagram to continue.
Okay, but the mobile crisis unit was through the CMHC, and now it's going to be through somebody else. I think that's the question.
That's the big question.
Okay, and we can't speak about that today, but I can come back fairly soon and talk to you about it.
Okay.
But the grid has not changed that we have shared. I've got a PowerPoint that I shared with you, Sheila, that procurement has allowed us to give out.
Yes, and I got it out to everyone. Oh, you shared it right after the January meeting, and then it got
So
lost.
as long as a provider can meet the criteria and the functions of the mobile crisis team, they're not going to be excluded, but they do have to meet the redefined definition of mobile crisis, which will be, we are submitting our SPA on that to CMS this month to be going effective in October.
Okay, and I think the other thing you probably can't talk about is money, but obviously one of the big questions that came up at the 988 call, because so many of the, the 988 calling, answering is being done by the CMHC, is anytime you bring in anybody else to do anything, it costs you money. So where's the money coming from?
So Sheila, again, I can't speak about all the pieces. There's lots of pieces.
Yes.
Even outside, we're trying to meet, if you've heard Leanne and I on the EMS TAC, we're trying to figure out ways that in these local little areas that maybe an EMS gets called, how they can treat, not transport, if they're the only person that's available or something like that. We're trying to figure out other transportation methods right now too. So I know you all hear us on a lot of tags, so there's probably those add on extra questions. So again, we'll try to come back very soon and give you more than just the summary today.
Okay. Here's somebody on from Volunteers of America Mid-States. And what's your question, please?
I didn't have a question, but this is my first time attending these meetings, which is fantastic. I appreciate the invite that I got from a colleague of mine. If you could just send me the invites for future meetings, I'd like to continue to attend, but this information has been really great and I love the presentation with the data.
If you will send your information to the email that's at the bottom of the agenda, kyadvocacy@gmail.com. I will do that, and that's true for anybody else. I keep a list and send everything out to everybody that's interested. Thank you. Kathy Adams, I think you're on, and Steve, what about number and requirements of MCO audits? There been any change one direction or the other?
Nina had her hand up, guys.
I'm sorry.
Nina had her hand up.
Oh, Nina?
lot of opportunities for synergy in terms of linking resources, volunteers, and so on. I sit on a CIT meeting, and New Vista had the 988 team there, as they always do. And one of the problems that they reported was not having a sufficient number of volunteers. And so we have linked our CIT to our community coalition meeting, and also linked 988 to come back to our KHA Behavioral Health Forum, so that we can more broadly broadcast the need for volunteers. So just a reminder for folks that are on CITs and or community coalitions to connect those dots for resource development in particular. Thank you.
Nina, if you'll drop me an email, that would be helpful. And I'll get that out to people. Because I may not have captured all of that. Okay, on to audits. Where are we with MCO audits?
This is Kathy with the Children's Alliance. I have not heard a whole lot from my members recently, I guess since the holidays really. I think their biggest panic point at this time is the extended service codes. That's kind of flipped their world upside down and their ability to serve their clients. So I really haven't heard much. I did hear from one of our members. I'm aware of at least 2 of our members that have appealed audit findings all the way to the end of the process, you know, where you're hiring an attorney and you're having to mediate, etc. And both have come, the results of the audits in their appeal processes have come out favorably on behalf of the provider. So I will share that information. Of course, it's expensive to fight an audit finding in the appeals process. But I do know of at least 2 members that have been successful, one very recently.
Yeah, thank you for sharing that, Kathy. Steve, are you hearing anything from the CMHCs?
No. Yeah, neither way, more or less, you know. So I don't think there's any change from our perspective.
Okay. All right. I put on here, you all may have heard that there's a legislative session going on. There are a couple of mental health bills that are moving so far, and some things that we've been supporting. There's a bill on addressing perinatal mental health issues that has passed the Senate. That's Senate Bill 135, and passed the House committee today. It would set up every birthing place would give more information. And then the cabinet would be pulling together a list of health and mental health providers to really do some brainstorming about how to better inform not just moms, but dads. The ratio apparently, or moms, about 1 in 5 moms are going to have some perinatal mental health issue, but 1 in 10 dads, which I think is fascinating. There also is quite a racial discrepancy, as there is in mortality and morbidity for Black and brown moms. There also is in terms of access to mental health services and so forth. Our folks over at the homeless and housing groups are trying to make IDs, lower the cost of IDs and make them available to homeless use and youth, and allow driver's licenses to be renewed for the homeless. And that bill has passed the House and gone to the Senate. There was a bill to exempt providers from prior authorizations, and it passed a House Health Services Committee, but has been reassigned to another House committee and probably is not going to go anyplace. House Bill 196 is Ken Fleming's bill to establish what he's calling Safe KY. It's an app for students to use that would put them in touch with a licensed mental health provider. There's a pilot program in it that would be Jefferson County and 2 other counties. I'm not sure how that's going to interface with 988 eventually, because I think 988 is able to be reached by text and chat at this point. He also has a bill on workforce scholarships that would include both health and mental health providers, and it has passed the House. Representative Weber has House Bill 148 that would require insurers to pay out-of-network providers directly and not by assignment to the policyholder, which has been a real issue for some providers, and it's passed the House and gone to the Senate. Representative Moser has House Bill 353, which is a harm reduction bill to remove fentanyl test strips as drug paraphernalia in criminal statutes, and it has passed the House, and I think there are a lot of SUD providers that are very eager to see that get passed. And then Steve has done a lot of work on House Bill 248, which would put some licensing zoning oversight for recovery housing. And it's passed the House and is on its way to the Senate. There are a ton of bills that we really like banning conversion therapy and some other things that have not moved since day one. We have several bills that we are really working hard against, and they have to do with really terrible discrimination against our trans young people. One is Senate Bill 150 that has passed the Senate and gone to the House Education Committee, and it would absolutely negate the ability of even parents to have their students to be called by their preferred name or pronouns in the schools. It I think really creates a hostile environment for students that think they may be trans or think that they need to be identified differently. I think it's going to put teachers and school personnel in a really, really difficult situation. It also is going to open up, information to parents, which I think is a good thing, but it's the parents' rights in this go one way, but not the other way. So if I'm the parent of a trans kiddo, I'm not, the schools don't have to follow my request to have my son called by a different name or use different pronouns. But the worst bill is House Bill 470 that unfortunately passed the House on Thursday. And we've been told by 2 national groups, Mental Health America nationally and ACLU, that it's the worst anti-trans bill in the country. It had both health and mental health providers in it. The mental health providers have been taken out, but the health providers are still in, and they would be subject to losing their licenses and having criminal, I think they took criminal penalties out, but civil penalties for providing even information and counseling to trans youngsters, much less doing anything like puberty blockers, that kind of thing, would make them liable for 30 years after the youngster turns 18, which is a statute of limitations longer than anybody has ever seen. So we are extremely concerned, and I guess my response to, yes, the mental health providers were taken out of House Bill 470, but we know that if you shut off for trans kids and their families any access to medical advice, consultation, beginning treatment for these gender dysphoria issues, that it will have significant mental health impact on an already vulnerable population. So we encourage providers to reach out to senators in opposition to House Bill 470, and on the Senate, in the Senate, and on the House side to oppose Senate Bill 150. I think I mentioned that we had a recommendation to the MAC on communication around the ABI issues, and we've not heard back yet. For our voting members of the TAC, are there any recommendations that you would like to see us make to the MAC for their March meeting?
Sheila, this is Mary. I would like to continue the conversation around the mobile crisis entity that Leslie was talking about. I don't understand how a staff residence is excluded. But anyway, I would like to continue that discussion on the behavioral issues because we lost under when it was Adam Meyer was secretary, we lost our neural behavioral entity that we had at Eastern State. So really right now, brain injury is really in a crisis. We really have nothing to reach out to if someone, either the individual is in a crisis situation or that person then is causing harm to other individuals in a staff residence. What the providers of the staff residence is saying to me is if the person who's causing the abusive behavior to the other people in home, unless they are causing harm to themselves or voicing harm to themselves, they have nothing they can do. That's the situation I've been told. So it's a serious situation because literally right now, brain injury is left without any type of crisis stabilization.
Mary, let's, I hear your concerns. Let's put that at the top of the agenda for our May TAC meeting, because I'm not sure that we have a recommendation for DMS.
Okay, that's fine. I didn't know if there was anything to continue the conversation with Leslie. If not, we can wait till May. That's more than fine.
Well, and what I'd like to do, because I think we communicated to Leslie and Leanne, have Leanne ask those specific questions in her daily, it sounds like, communications with CMS. So I think we need to get some basic information.
We'll reach out, Dr.
CMS.
Schuster.
Yeah.
We'll reach out. Yeah, the only specific questions I've asked about so far were the children in the Michelle P. waiver who are not in residential. So we'll follow up and let you know.
Yeah, and let's Mary, you and I could talk offline about whether there are other people that we might invite to the May meeting to advise on some of these issues around the ABI folks.
Okay, thank you, Sheila.
Okay. Yeah, sure thing. So we have some repeat agenda items as always, but we're very glad to take off the dual eligibles. It sounds like the mobile crisis really needs to get elevated to a more robust discussion at our May meeting, both in terms of ABI, but just generally, I'm still concerned about the interface with 988 and so forth. Any other agenda items for our May meeting besides carryover? Anything new? We may need to be looking at if House Bill 470 passes. I think we need to be talking about increased awareness for behavioral health providers for what I think is going to be increased need in this population. And that's not necessarily just a Medicaid pay population, but I'm sure that there are children that have Medicaid services that will be affected by this as well. Anybody have any? Yeah.
It's Kelly Gunning. Just the thing I wanted to say as a follow-up to what you just said about 470. I think we're creating such a hostile environment and the kids don't really have any choice but to go to school. I mean, they have to go unless, their parents homeschool them. And I'm just like you, really, really concerned. There's already a lot of bullying going on, a lot of suicidal ideation and gesturing. This can improve that whatsoever. So we need to be prepared to, how are we going to negotiate with these people, these hostile environments?
Yeah. Well, and I think
just the message is so hateful. Just the message is so dehumanizing.
Yeah. Yeah. And that's what I heard in Frankfurt. I was there the day of the House Judiciary Committee meeting, and the room was filled. The overflow room was filled. The hallway was filled, and people were very quiet and respectful. That was what the chairman asked. They didn't, there were no, interruptions and so forth. But the outpouring of emotion when that vote was taken was really quite overwhelming. There was anger, but it's always easier for people to express the anger, I think, almost immediately. But there was so much sadness and fear. And I talked to several parents up there. I sat next to a woman whose 19-year-old son is trans, and she said he's happier than he's ever been in his life, and he's a student in college, and she's a teacher, a public school teacher, and she said, I just sit here, and she started crying, and she said, if they had passed this bill 4 or 5 years ago when we were struggling to get mental health and medical care for our son, our daughter at the time, she said, I don't know what we would have done. She said it was so important for us to be able to get that consultation and that care, and to have providers to go to. And she said, I think we would have had to move out of Kentucky. I can't think how else we could have dealt with that. So there's a real sense of attack here.
Well, the thing that's so disconcerting is that, according to polls, 71% of Kentuckians oppose this legislation.
Right.
71%. So, I mean, what is this?
Yeah.
How could this even be happening if they're listening? Oh, yeah, I'm sorry, they're not.
Yeah, I mean, I think, that is the most disturbing thing is how does this hurt anybody else? This it doesn't hurt anyone. This is a very personal attack, it feels like.
I disagree, Kathy. I think it hurts everybody, because I think it's a violation between religious and church and state, just permeating through everyone's everything.
Well, I mean, I certainly don't disagree with that, Kelly. I just mean, what does it hurt anybody else for someone to live their life as they choose to?
Oh, I agree with that, but I mean, the legislation is very hurtful.
The legislation hurts everybody. I completely agree. I'm just talking about, how does it affect anybody else? If a child feels that they're born into the wrong body and they want to make, they want to go through the process of change. I mean, that is up to them and their family. It's very deeply personal. And I do think families that have the means will leave Kentucky. And I think that's also very sad for Kentucky.
So. Sad.
Yeah. Let me wrap up here because we're about out. I don't think there's been any change in the most recent prior authorization guidance, which I think goes back at this point, well, back into 2022. And yeah.
Yeah, this is Bart. Just real quick, if I may. A couple of things that kind of goes with the last couple of agenda items. Maybe as far as old business, but also something for the next TAC meeting.
Mm-hmm.
As we're ending the public health emergency in May, I think there's several items. One, the prior authorization guidance, my understanding is that DMS can continue to have that in place past the public health emergency. So that was just a question, I think, to see what the decision will be from Medicaid on that. And also some of the things that were allowed under the public health emergency that might be ending. I know these are questions that the folks at DMS are wrestling with now. So I'm not asking the question for an answer now, but I just think that that's something that for the May TAC meeting would be very timely, since that looks like it's actually the exact same day that the public health emergency is. So.
Yeah, excellent, Bart. We'll put that in.
And just on the other issue, I was in the overflow room with you for that testimony. The testimony for the bill was very weak. The testimony against the bill was very strong. And the vote still went the wrong way, but so it was very discouraging. So,
Well,
very sad.
yes. And on the floor of the House, the bill sponsor, Jennifer Decker, spoke in favor of the bill. And there was one comment from one other Republican, and every Democrat, I think, in the caucus spoke against it, and 3 Republicans spoke against it. And yet the bill passed 75-22. So people voted for it, but didn't want to be. Somebody said to me that they didn't want to have a clip with their saying something about the bill, which tells you something. Anyway, yeah. Bart, thank you for bringing up the unwinding and the end of the public health emergency. We will definitely put that on the agenda for May. The next MAC meeting is the 23rd of March from 10 to 12:30. And then we will meet on May 11th, and we'll go back to the regular 1 to 3 timeframe. We have been meeting from 2 to 4 during the legislative session to accommodate that. So, and I look at my clock and it's right at 4 o'clock. So if no one else has anything to add, I want to thank DMS for being with us for sure. And DBH, GID, I see Dr. David Sussman, who is a advisor now with DBH. Thank you for being with us, David. And thanks to our voting TAC members, and thanks to all of you who have joined us today. And I will see you in 2 months. And thank you, Kelly Sheets, for facilitating things today.
Absolutely.
Thank you, Sheila.
Yeah, thank you all. Take care.